Okay, so first we're going to start with heart failure. Go into the module. Okay, so you'll find heart failure in your med-surg book, but as I mentioned before, you will be able to see everything that is critical for you outside of the med-surg book and in lecture and in the PowerPoint. All right, so heart failure is a syndrome. And actually, we have a video. Before you go through all of this, I do want you to watch this video on slide number 7 on systolic heart failure. So before you get any further into this, double back and watch that video from slide 7. Okay. Again, so heart failure is a syndrome. You have the fluid overload. So those signs and symptoms again would be weight gain, cough, edema, nocturia, all those signs and symptoms of too much fluid on board. So you have inadequate tissue perfusion, which leads to fatigue, dyspnea, and fluid retention. And heart failure is going to indicate that there is some myocardial disease. So either a problem with contraction, which is systolic, or a problem with filling, which is diastolic. So causes for heart failure. So I have some listed on my end here out of the Lewis book, but so some primary causes would be chemo, diabetes, valvular heart disease, hypertension, vascular disease, genetics, alcohol use, different meds. It could be post-viral. It could be from sarcoidosis and hyperthyroidism. Some precipitating causes, again, they can be found on Lewis page 738, but some of those would be anemia, infection, hypothyroidism. And the result is going to be decreased ventricular function and manifestations of heart failure. So you're going to see that decrease in cardiac output, that decrease in systemic blood pressure, the decrease in the perfusion to the kidneys. So the body's response to the myocardial dysfunction is essentially a stimulation of the sympathetic nervous system neurohormonal response. So again, there was that video that I wanted you to watch, which you'll find on the next slide, but there's also a specific blood test for the diagnosis of heart failure, so a BNP, and that is produced by the heart muscle, and it has a couple different renal, cardiovascular, and hormonal effects. So it diureses by excreting sodium, it vasodilates, it decreases blood pressure, and it also inhibits aldosterone and renin secretion and interferes with the release of ADH. So systolic heart failure. So it's weakened heart muscle. The pump just can't pump effectively. It could be due to cardiomyopathy, damaged heart from an MI. It could be a abnormality in the valve, something mechanical, or an increase in afterload or chronic hypertension. So again, that could be due to genetics, smoking, again, alcohol. We see this weaved throughout our entire course, lifestyle, stiff vasculature, or left ventricular hypertrophy. So your ejection fraction, which is going to be best seen on a 2D echo, it is the gold standard, and it does assess the left ventricle. So normal ejection fraction would be 55 to 70%, somewhere around there. So again, the 2D echo is going to be your hallmark for diagnosing this systolic heart failure. And in systolic heart failure, we have that weakened heart muscle. We have a decrease in the blood volume ejected. So thus we have a decrease in the ejection fraction. So left-sided heart failure, if you can remember back, left equals lung. So those symptoms are going to be due to that increase in the pulmonary pressure. So we're going to see shortness of breath. We're going to see a decrease in the pulse ox. You're going to want to put the patient in high Fowlers and put on O2 if necessary. So you're going to see that decrease in oxygenation and all those lung symptoms. The decrease in cardiac output is going to result in inadequate perfusion to the tissues. So, early signs and symptoms of a decrease in cardiac output are going to be the confusion, the fatigue, the feeling of being lightheaded. We're also going to have inadequate perfusion to the kidneys, the periphery, GI, the brain, and also the nervous system. So in diastolic heart failure, typically you have the stiff, non-compliant heart muscle. The ventricles are having difficulty in filling the preload, which is the relax and fill. LVH, which is left ventricular hypertrophy due to that chronic hypertension. Aortic stenosis, hypertrophic cardiomyopathy. And this is going to result in a decrease in stroke volume and cardiac output, the vascular system, and pulmonary engorgement. So the diagnostic tests are going to show a normal EF. They're going to show pulmonary congestion, pulmonary hypertension, and the ventricular hypertrophy. We also have mixed systolic and diastolic heart failure. And the systolic heart failure video that I'd like you to watch is right here. So right-sided. So I think of left lung, right rest of the body. So it's the inability of the ventricles to relax and fill during diastole. So your symptoms are going to be normal EF, pulmonary congestion, which may be a little confusing because we just went over lungs on the last one, but evidence of left ventricular diastolic dysfunction, and that will be seen on an echo or on a cardiac cath. So those systemic rest of the body symptoms are going to be the dependent edema, ascites, weakness, weight gain, anorexia, nausea. Something that you wouldn't necessarily see would be hepatomegaly. So the primary causes of right-sided or diastolic heart failure: pulmonary hypertension, an infarct in the right ventricle, pulmonary embolism, cor pulmonale, or the mix of the systolic and the diastolic heart failure. So your clinical manifestations of chronic heart failure. So chronic heart failure is a progressive worsening of the ventricular function and this chronic activation of the sympathetic nervous system. So we teach our patients and family this mnemonic. It's called FACES. Fatigue, A for a limitation in activities, C for congestion, cough, and chest pain. So we get to cover 3 with that one. Edema and shortness of breath. There is a table that lists them all, but these are going to be the most important ones for you to remember. So your assessment and diagnostic findings, again, that 2D echo is going to be your gold standard. It's the most common tool for heart failure. You're also going to want to get a good HMP. A chest x-ray could be indicated. An EKG, of course. A BNP is going to be your key diagnostic indicator. Get some electrolytes, the BUN, the creat. We can also do the 6-minute walk test. We have a stress test, the MUGA scan. And that MUGA scan is going to be a test that uses a radioactive tracer. So it's going to be taking pictures of your heart as your heart is pumping blood, and every heartbeat, it's going to let us know how well that's occurring. So it's also done to rule out an MI. We can also do nuclear imaging, and then there's cardiac catheterization. Lots of different diagnostic tools. So some complications of heart failure: pleural effusion. That is a result of the increased congestion in the pleural capillaries. Dysrhythmias, that's due to the enlargement, and that's going to cause an alteration in that electrical pathway that should normally be occurring, especially in the atria. Left ventricular thrombus, hepatomegaly, which leads to cirrhosis, and renal failure, which leads to renal insufficiency or failure. And constipation, I always like to throw in here, due to a decrease in activity. And, people just aren't moving as much. As we talked about before, there's those couple things: the diabetes, tough, that really puts people at risk for all these other things. Heart failure, another one of them. COPD is another one. So, the restriction of movement leads to all these other things. And I always like to double back to constipation in all the different areas so you can see how it affects everything. So the classifications of heart failure. So we have the New York Heart Association, and then we have the ACC and the ACH. So let's look at these. They can be quite daunting to look at. So this is the nicest one of all of them, just because of the simplicity of it. So we have, 4 stages. So we have number 1, cardiac disease, but there's going to be no symptoms and no limitation to everyday normal physical activity. Number 2 would be mild symptoms and only a little bit of limitation during those things that you would normally do. Number 3, we're going to have significant limitation in activity due to those symptoms, and they are comfortable only when they are resting. 4 is going to be severe limitations and severe, and now that is severity is while at rest. So you can see how they stack up against each other. This is the heavy hitter. So we have the ACC and the AHA. As a practitioner, you would get to choose which one you wanted to follow, but obviously you would stick with one. You don't want to float between the two, but it has a really great way of looking at it and telling you how to handle it. Really what I want you to know is that there are 4 stages, just as in the New York heart failure classifications. Stage A, you would see at high risk for heart failure. Again, no structural disease or symptoms. B, now we do have structural disease, but we have no signs or symptoms. C, we do have structural heart disease, and we do have some symptoms. And D is going to be in that refractory period where they're having those symptoms even at rest. So you can see how they are very much alike. These just show you what type of patients you might see, and then what type of therapy you would want to use with them. Pay close attention to those being at risk for liver cirrhosis related to severe hemodynamic changes. So that increase in cardiac output, that increase in heart rate, that decrease in the systemic vascular resistance. So definitely want you to just understand that this is out there. So interprofessional care for heart failure. So as far as care is concerned, acutely, we would want to diurese, O2 as needed, hypertensive meds as necessary. Chronically, making sure we're looking at the CBC, getting, making sure there's no anemia, looking at, a BMP or CMP, looking for some renal concerns. Is there any chronic kidney disease? Do we need an EKG? Yes, of course, in both situations. The 2D echo. Can we get the TEE, the MUGA, the stress test? Looking at the an evaluation for the ischemia. You can see on page 744 the table 34-6, but again, you should find almost everything that you need in this lecture and also in the PowerPoint. So, as heart failure advances and progresses to the end stage, knowing that the metabolism of drugs decreases is also going to be critical for you to understand. Diuretics are going to be used to decrease that intravascular volume, vasodilators, morphine. Let's see, we have a couple different inotropics. So, dopamine, dobutamine, and norepinephrine are only used for short-term use. Milrinone, you'll see that often in the hospital. It's not typically used in any other setting. And DIG is tough. It requires that loading dose and also time to work. And we really don't want to have to use it just because of the complexities of the drug itself. Okay, so interprofessional care. So the critical patient is going to go into ICU, and if they can go into the step-down unit or tele unit, that would be great. If they're in the ICU, we're going to be monitoring their heart, checking their O2 sats, their vital signs, the urine output, making sure they are, not hemodynamically challenged. Maybe they need an arterial line. Ultrafiltration would be used to remove that excess salt and, making sure we're maintaining those hemodynamics and, keeping them stable. So collaborative care for those with chronic heart failure. So the goal and this is important, is to treat those underlying causes and contributing factors. So example would be hypertension. We want to maximize their cardiac output, reduce symptoms when we can, improve that ventricular function, improve their quality of life, always trying to preserve those target organs and reduce the morbidity and the mortality. So the pharmacologic therapy for heart failure, again, right now the goal is to decrease the blood pressure and the afterload, relieve any of those signs and symptoms, and then prevent any further progression of heart failure. So you're going to see people with chronic heart failure on diuretics. They're going to be on an ACE or an ARB, an aldosterone antagonist, a vasodilator, a beta blocker. Maybe you'll see them on one of those inotropic agents. And if they have had a history of AFib or have had a thrombus in the past, you may also see them on anticoagulants. So ambulatory care, so again, you're going to be looking at the signs and symptoms to monitor, and report. So again, if someone was having dizziness or fainting or a dry cough or breathlessness, those would be things that would need to be transitioned up. So if they weren't responding to treatment, you would want to make sure you discuss hospice and palliative care, because if someone was on stage 4, we're sort of at the end of the line. So anything we can do to prevent them from getting there. But once we are there, we do need to discuss that with them. We want to teach the patient those physiologic changes that take place and, help the family adapt to those changes, making sure that you're including the patient and the caregiver in the plan of care. Also, heart failure patients require education and re-education on how to manage this type of diagnosis when they get home. So, anytime we can include caregivers to promote success and adherence, such as how to use their meds properly, making sure that they're checking their weight daily, when to worry about their weight. So typically the standard is 3-pound weight gain in 24 hours or 5-pound weight gain in 1 week. Making sure that they understand the importance of getting immunized, despite, what some people may think it is important with someone, with chronic heart failure to keep up on their immunizations. In an acute care setting, you'd be checking their eyes and nose. In an outpatient setting, making sure they're sticking with their follow-up appointments, that they, monitored their activity and they're active when possible. Let's see. So if someone needed a heart transplant, the criteria is on page 753. You won't be tested on this necessarily, but there is a bridge to transplantation. There's lots of different devices that can be used to keep someone's heart ready until we're able to get them a new one. The procedure is quite long and there is a huge risk for rejection, and they would be using them long-term due to the infection risk, and the steroids would need to be used long-term. So that can be just as challenging as managing a heart that's failing. We also need to make sure that we're helping the patient adapt, monitoring the heart function when we can, and anytime we can manage those lifestyle changes, because it is going to be different for them. And again, always teaching for the patient and also the caregiver. So your nursing diagnoses would be excess fluid volume, impaired gas exchange, activity intolerance, and again, activity intolerance leads to constipation. We have a decrease in cardiac output, deficient knowledge. It's such a difficult process to manage. Powerlessness, and that really is due to just being chronically ill, in and out of the hospital, and also nutritional deficit. So your nursing process, you're going to want to make sure you plan and implement how they can decrease their symptoms and decrease their edema, increase the tolerance in order to, be mobile and exercise, how to control their anxiety, how to, and this is a big one, be compliant with their medication and overall healthcare regimen, how to minimize feeling powerlessness, monitoring any potential complications, which, can creep up pretty quickly, promoting home-based care and also community-based care rather than being in and out of facilities all the time. And any time that, end of life needs to be discussed. Of course, we do that when that's appropriate. Palliative care, end of life care. So heart failure is a terminal disease. We do want to make sure we, understand that palliative care should come in as early as possible. There's a very fine line of when that time is, but as long as we are honest with the patient and educating them on their prognosis and where they're at in the process and their survival, we can put together a pretty good plan. You need to make sure that advanced directives are in place, that there is really good continuity between the patient in any settings that they are rotating between, and managing any type of pain or suffering that they may be having. We can implement hospice when they have 6 months or less to live. So with end-stage heart disease, we're doing that ongoing assessment and evaluation, making sure, again, we're intervening and that we're monitoring that our interventions are effective, monitoring the patient, supporting them, supporting the caregiver, supporting the families, implementing any drug and non-drug therapies, as indicated, discontinuing medication when they're not tolerated, or when, at some point they just aren't necessary anymore. B12 is not going to be important, and calcium when someone's in those last, 6 months. The priority is going to be always providing comfort and relieving suffering whenever possible. Your evaluation, just making sure that the patient is demonstrating tolerance for any type of activity. Doesn't necessarily have to be increased, but maintaining the balance in fluid, that their anxiety is at a tolerable or acceptable level, that they're making good decisions regarding their care and their treatment, and that they're also adhering to the regimen of self-care and caring for themselves as best as possible. All right, so let's go into stroke, which is also going to be in your med-surg book, and we went back too far. Okay. All right, so stroke starts on page 1345. Okay, so health promotion and disease prevention. So the big thing with strokes are, that what puts them at risk: hypertension, diabetes, smoking, again, alcohol. So early treatment of hypertension and any type of underlying cardiac problem, maintaining good blood glucose levels, refraining from smoking, keeping a healthy weight, exercising regularly, are all going to help promote the reduce, I should say, the risk of strokes. So some risk factors: diabetes, aneurysm, sleep apnea, atherosclerosis, cocaine use, valvular disease. The list is on page 1400 in table 58-8. So some of those subjective symptoms. So fast, now I know they have changed this a few times. I think there was fast and faster, fast maybe with two S's. So the one that we want you to know is the simple FAST. So facial droop, arm weakness, speech difficulty, and time to call 911. So they're going to have these reports of these visual disturbances, feeling dizzy. You're going to see, or they will explain to you that they have weakness in one of their extremities or more than one extremity, that their speech is suddenly slurred. So a TIA, also called a mini stroke, is going to be an early warning sign of a stroke. Those symptoms are typically going to resolve within 24 hours. So objectively, so the symptoms are going to vary based on what type of the brain, or what area of the brain is affected. So, that deprivation of oxygen, it would be important for us to maintain their airway when possible. Again, depending on what setting we're in and what kind of supplies we have available to us, but assuming we're in a acute care setting. So left cerebral hemisphere stroke. So left is for language. So they're going to have that inability to speak and understand language, expressive and receptive aphasia. Agnosia, which is that inability to recognize familiar objects. I had a patient who I was certain she was having a stroke, and I showed her a pen and she called it a word I've never even heard before. So I started picking up items, and she was, pretty clear in what she was saying. Her speech wasn't too garbled, but she was calling every object something different. And immediately I knew something was wrong. We got her to the hospital very quickly, and she did very, very well. Agraphia, writing difficulty, that hemiplegia on the right side, left stroke, right side, that slow, cautious behavior. They can become depressed, angry, frustrated, and oftentimes they have those visual changes where they can only, hemianopia, which is only on one side. And then again, you can see more of those on the table. So the symptoms of a right cerebral hemisphere stroke. So right for rhythm, left for language. So rhythm. So altered perception of deficits. So they overestimate their abilities. One-sided neglect syndrome. So they're ignoring left, again, because right is on the left and left is on the right. They cannot see or feel or move, or, that dead arm, it's just sort of hanging there. They can't feel it. Loss of depth perception. They have impulse control that is poorly managed, and judgment is poorly, they just can't make good decisions. That left hemiplegia or hemiparesis, we're going to have those visual changes again. Also, they're at risk for hypothermia, so it's definitely important to look at their temperature and know that they can't regulate their temperature. So those diagnostic studies, the CAT scan is going to be done on arrival, and that is to rule out whether it's going to be ischemic or hemorrhagic, looking to see, is there edema, is there necrosis? The MRI, will be done later, and that's going to be to determine, the hemorrhage, what the blood vessel structures look like, what the perfusion looks like. You can do a Doppler and angiography, looking for any type of stenosis. The Glasgow Coma Scale, which is, quite famous, everybody's heard of it. That's used to determine that level of consciousness and orientation. So their risk for an increase in their intracranial pressure is going to exist, and that is really due to that swelling of the brain that can happen secondarily to the ischemic stroke. Again, there's more studies in the book if you'd like to look. So your nursing care, blood pressure control, it needs to be as tight as possible. We want to keep people under 180, over 110. If it goes too high, could be indicative of another stroke, but we also want to be responsive to low blood pressures as well. Looking at their temperature, when it's elevated, that fever can increase the intracranial pressure, making sure that their O2 stats are above 92, or if they have a decrease in level of consciousness, that we check their oxygenation, that we're assessing for any type of arrhythmias, that we're looking for their rate and rhythm and seeing if there's any irregularities. Again, looking at those changes in level of consciousness, so that we're looking to see if there's any type of increase in their intracranial pressure, monitoring the vital signs every 1 to 2 hours or more, depending on what situation that you're in. It could be as much as every 5 to 15 minutes. NPO, we want to treat nausea and vomiting very quickly. It can stress the patient. Making sure we get the EKG, keeping the head of bed elevated to make sure that the intracranial pressure is decreased as much as possible, and promoting that, the venous return, keeping the head in a neutral position so we're not, flexing it or extending it. And then anytime we need to implement seizure precautions, we can do that as well. So the collaborative care, we're going to be managing the blood pressure, again, highs or lows. In acute care, we're going to make sure that we're maintaining their fluid therapy, of course, as ordered. So the TPA, I want you to understand the criteria for inclusion or exclusion for this treatment. So understand that it is used for ischemic stroke only, which is one of the reasons why we're getting that CAT scan right away, so we can decide what we're going to be doing. So if it was hemorrhagic, we would understand that they would be at an increased risk of bleeding if we gave them the TPA. Treating the arrhythmias, do we need anticoagulation or do they have AFib? Are they on any platelet inhibitors? Anti-seizure meds, when indicated, again, that's a priority, always to monitor for seizures because they can happen. And then any type of meds, you may see some on there for cerebral edema as well, or cerebral vasospasm. So collaborative care from a surgical perspective, the TPA, if it was indicated, they have those stent retrievers or the Mercy retrievers to go in there and grab the clot. We can do the surgical decompression to clip or the coiling of an aneurysm. So that would be indicated in hemorrhagic stroke. And then there, again, are some other surgical therapies listed in the book. So the post-acute phase. So we want to anticipate any of these objective data findings and create a really good care plan based on what we have seen the patient exhibit. I do want you to understand what the stroke scale is, know the components of the stroke scale, and then what items you would evaluate and how to know and interpret each score. So some other post-acute hospital phase considerations. So elevating that affected extremity to promote venous return and reduce the swelling. Teaching the patient how to massage the affected hand to get the fluid moving and get it back up into the wrist and the arm. Always making sure we're reducing falls or keeping people safe, making sure the environment is safe. Anytime we can use adaptive or assistive devices, that is excellent. Making sure the patient understands to scan entire areas before they do things. That includes eating or walking. You always want to position yourself so they can see you. DVT prevention is going to be critical, making sure that they're using some type of compression, stocking, position changes as often as possible, and mobilization when appropriate and possible. Having them understand that they need to address the affected side first, and anytime they can sit up and balance as best as possible, that is preferred. Using those appropriate devices to aid in dressing. They have grabbers and sock putter-oners and shoe horns and all different types of stuff that are extended, so they're great. With eating, you want to make sure that they're positioned well, that you're doing good oral care. We do want to prevent aspiration pneumonia, so if they aren't swallowing everything and they're pocketing it, we do want to know that, especially if we're going to lay someone down afterwards and the food's going to dislodge. OT or speech can also help assess with those feeding needs and provide any of those adaptive devices that will help out. So preventing immobility complications. So the complications, the big one's going to be pneumonia, also pressure sores, DVTs, loss of limb contractures. So intervening with that, you can teach them how to dangle the extremity, lifting it. Therapy is going to do a lot of that with you. Incentive spirometry, coughing and deep breathing, making sure you're doing really, really good, thorough lung assessments with good documentation. Monitoring the temperature, of course, keeping that head of the bed elevated 30 degrees, ambulating them as soon as possible and when safe, with the appropriate staff involved to help you if it's someone who needs more than one person. Repositioning them frequently. Anytime we can pad things or monitor those bony prominences, especially on that affected side, because they will not feel pressure. Preventing injury. So if they have that one-sided neglect, we need to protect that extremity. We need to teach them how to scan the area. I've seen too many times people slam an entire arm in a door because they're not aware of the body part. Performing those ADLs to that affected side, as I mentioned, and encouraging that passive range of motion every 2 hours, more often if possible, but at least every 2 hours to that affected extremity. So the communication, you want to assess their ability to understand speech by asking them questions, simple questions, and seeing if they can follow commands, making sure that they are giving you consistent answers and that they are consistent with, what you're asking them to do, and that they comprehend, that you're assessing, yes or no questions in relation to times that you can ask closed-ended questions. It's very easy for people to say yes or no, and they have a 50% chance of, getting the answer that you think that they should get. Anytime you can give someone a picture board where they can point to things that they may need would be helpful. Of course, speech therapy is going to be involved to help with their gag reflex and how they're swallowing and how they're chewing, incorporating any swallowing techniques, and that would all be done again by speech therapy. If they are not doing well, they likely would change the consistency of their food. We want to avoid that aspiration, pneumonia risk. Anytime we can put the food on the unaffected side and making sure that we're checking for pocketing is going to be very, very important again for that aspiration. Again, we want to have the suction nearby if need be. And maintaining a distraction-free environment is important because, you know, eating is a very social thing and people like to talk and look around, and you'd be surprised how much that can interfere or become a risk for choking for somebody who really needs to focus on exactly what they're doing. So complications, so dysphagia and aspiration, again, as I mentioned, due to that impaired swallowing. So making sure we're checking the gag reflex, consulting with speech therapy, and making sure that they are clearing their throat, you know, taking a sip, swallowing multiple times to make sure that everything went down. But again, making sure that suction is available is going to be important. That unilateral neglect, making sure that affected extremity is not being beat up. Impaired urinary and or bowel elimination is going to be very common. We do want to avoid the use of indwelling catheters. Anytime it's indicated that someone needs to be cath, we can do the intermittent straight cath, and we can schedule elimination times, and we can add in a bladder scanner, which can be helpful. You know, oftentimes you'll see in water, you know, 4 or 5 times a day, we're scanning the bladder. If there's so much in there, we cath. If not, we put them on the toilet and try to let them get things moving. So I've seen people that you wouldn't even believe that they would ever be able to go to the bathroom again on their own, that within a short period of time with scheduling the elimination and putting in that intermittent catheterization, they can, you know, get that one thing back, which is very important to people. Impaired physical mobility and verbal communication, as I mentioned, and situational low self-esteem. You know, we want to encourage them to complete tasks and perform self-care as often as possible, and making sure that they're appropriate to their current state. So we don't want to have a blanket statement where, you know, everybody at this point should be doing this by themselves, or, you know, the neighbor is able to do this and she had a stroke. You know, whatever they're able to do is what they're able to do. It's not going to be, it's individualized. It should not be compared to anybody else. Impaired urinary and or bowel, as I mentioned, we may need to do that intermittent catheterization, and of course they're going to be at risk for constipation. So anytime we can get them on a schedule for that as well, where they have private time and time to sit, and we're not rushing people. Also, some other complications, coping. It is tough. A lot of times people are on the younger side, you know, they're still working, or their spouse is working, and or their spouse isn't working and they were the primary person. So, you know, they're going to be challenged by that. They're going to be emotionally labile. You may see anger in somebody who, you know, family says they didn't demonstrate this before, and now all of a sudden they're yelling at their family members, or they're being explosive. Sexually, this could be very frustrating. You know, again, maybe this person's in their 50s or 60s and they were having a healthy, you know, sexual relationship, and now they're not able to. So, and anytime we can encourage community resources for the victim or the patient, as well as the family and caregivers and friends, is going to be a pretty important thing to do. All right, so we're going to move on to chapter 20, which is cardiovascular function. I usually like to do it right after the other one, but I'll do it in that order this time. So let's see what we have. Okay, so this is going to be in your Miller book. Again, chapter 20. All right, so let's see. All right, so the learning objectives, again, you're always going to see from the beginning, and I'd like you to really pay attention to those. So we have those age-related changes that affect cardiovascular function. So Again, these are throughout every chapter, we're going to have those age-related changes. So degenerative changes of the myocardium, we're going to have arterial stiffening, thicker, less elastic, more dilated veins, increased peripheral resistance. We have an altered barrow reflex. So some risk factors. So atherosclerosis is going to put you at risk for a decrease in cardiovascular function, physical inactivity, obesity, and especially abdominal obesity. Tobacco smoking is going to be your greatest risk, dietary habits, stress, depression, hypertension, dyslipidemia. Heredity plays a part in it, socioeconomic factors, of course, as we've mentioned, and then there are special considerations for women and minority groups. So the cardiovascular system effect on thermoregulation, so an inefficient vasoconstriction, we have a decrease in cardiac output, decreased peripheral circulation, and as well as diminished subcutaneous tissue and muscle mass. And these are going to result in a delayed or diminished shivering and a reduced ability to acclimate to heat. So the consequences of thermoregulation, so they are there's an increased susceptibility to hypothermia and heat-related illness. They're going to have a lower baseline temperature. You're going to see older adults between 97 and 97.4 orally. Those cardiac events can raise that temperature slightly during that very initial insult. And it is important that you know older patients do prefer their environmental room temperature to be 75, which can be smothering to many of us that are trying to take care of them in the summertime, and they like it, 80 or 85. So the probability of developing cardiovascular disease increases greatly in people who have metabolic syndromes. So, each of these in itself are risk factors for cardiovascular disease, but when we add them together, the increase is much greater. So lipid disorders, hypertension, and resistance to insulin. So the diagnosis is going to be made when someone has at least three conditions. So orthostatic and postprandial hypotension, so this increases with age, especially after age 75, and postprandial, which is after eating, hypotension increases with the following risk factors, so constipation, preprandial hypertension, type 2 diabetes, and Parkinson's. So for constipation, that would be the number one contributing factor to postprandial hypertension. We have that little old lady who's straining, sitting on the toilet, she's going to be at the highest risk. So symptoms are going to include sleepiness. This is postprandial hypertension. Sleepiness, nausea, headache, chest pain. Dizziness isn't usually reported in patients with postprandial hypertension, but this is going to be the most important symptom in orthostatic hypotension. So I don't want you to confuse those two. So again, with postprandial hypertension, so blood is going to flow to the digestive tract in your intestines after you eat, and that actually takes blood away from the other parts of your body. So, the treatment for that, eat smaller meals, so, the body doesn't have to do as much work bringing the blood in, avoiding high carb meals, again, not as much work, avoiding alcohol, and if they stay seated, if it's severe, lay down for 1 to 2 hours, but staying seated will help. So if you look at 20-9, there are both types of hypotension listed. So minority groups with higher rates of hypertension are going to be African Americans, American Indians, Mexican Americans, Native Americans, and some Asian Americans. Women's risk rises greatly after menopause, so we really have to keep a close eye on our lipids, especially the triglycerides. We want them less than 150. We want to keep the waist circumference low. So for men, it would be less than 40. For women, it would be less than 35. Want to make sure we keep that BMI in a normal range, so less than 25. It's actually 24.9. And there are some good statistics in your book that you can look at, but again, not testable. So nursing care for orthostatic and postprandial hypertension. So prevention and management, of course, we always want to promote health. Evidence-based practice says that diet and lifestyle changes are the foundation to preventing all disease. So again, any type of safety precautions that we can implement, assessing both types of hypotension. We don't want, people to get dizzy and fall and, break something. And anytime we can have really good nursing care and our interventions work, we're going to improve quality of life. So your teaching is going to include diet, exercise. We want 30 minutes a day, at least 5 times a week, or 150 minutes a week. Maintaining the optimal weight, again, BMI under 25. Smoking cessation when possible. Identifying those risks, everybody's going to be different. Managing hypertension or hypotension. And then anytime we can find those signs and symptoms of heart disease, we can hope to manage them. Again, all these come down to really good preventative care when people are younger. Unfortunately, by the time we get most of our patients, they're already older, and a lot of this has already been bypassed. So the negative functional consequences: a decrease in adaptive responses to exercise, increased susceptibility to hypertension or hypotension, an increased susceptibility to developing cardiac arrhythmias, and a decrease in cerebral blood flow. And finally, your wellness outcomes. We want them to have an improved cardiovascular function. We want to prevent cardiovascular disease, normalize that blood pressure, normalize their lipids, and hopefully help them live a long and life, that they feel they are getting a good quality of life. Okay, and last is going to be chapter 18. And 18 is digestion and nutrition. Okay, so let's get over there. That was before, okay. All right, so digestion and nutrition. Again, because it's in the Miller book, we have those learning objectives that you're going to see right away. You know how much I love them. Okay, so the age-related changes, again, we're going to start off with them again. They have a minimal effect on digestion and maintenance of nutrition. Surprise, surprise. There's very few functional consequences that actually result from these age-related changes, so that is awesome. It's the only chapter you'll find that in. Risk factors commonly occurring in the older adult, have a much greater influence, and adjustment of eating habits can really compensate for any type of age-related changes that they might experience in this realm. So their oral cavities, so the teeth are less sensitive, and they're more susceptible to fractures, breaking. People have fillings over the year, crowns and such, and you don't know how many teeth I've found in my life. A lot of people have dry mouth. That could be related to medication. It could be from many different things, but it does put people at a higher risk of infection because of the cracks and the fissures in the tongue. So over 65 years old, you have a 30% chance. Neuromuscular, decrease in the muscle strength with chewing and swallowing, and a decrease in the tongue pressure. They have a decrease in the sense of taste, but it's less in the sense of smell. And it can be affected by upper respiratory infections, head trauma, diabetes, and then some other things, again, as well as medications. So back second to decreased sense of taste, though lesser than the sense of smell. In addition to these visual changes, this can actually lead to issues like the inability to notice outdated or rotten food, which I did mention in our smell, in our chapter on that. So you add in this sense of taste and sense of smell and loss of sense of vision, and you're looking at people eating really horrible things, which is, again, I've seen this a lot. Age-related changes with smell and taste. Sense of smell declines more than the sense of taste. Many conditions can contribute to this decline in sense of smell. I've heard people that were in wars that said they came back and they can't smell anymore, that they were exposed to different types of chemicals. And again, that changes with different people, and the perception is different with different people. So it's one of those things that's subjective. It's really hard to pinpoint that. Degenerative changes affecting digestion in the small intestine, so decrease in mobility, permeability, transit times, everything's slowing down a little bit. In the large intestine, there's a decrease in the secretion of mucus and the elasticity of the rectal wall, and they cannot always perceive when the rectal wall is distended. So hence we have people who are constipated and or people who are incontinent. So Changes in older adults as far as nutrients. So in women, postmenopause, our iron levels decrease. The ability to synthesize vitamin D decreases as we get older. We less efficiently absorb calcium as we age. We actually have a greater need for B6 as we get older. And B12 is unchanged. The amount is unchanged. The ability to absorb is what changes. So although we can acquire it through fortified foods, that is tough. So, but anytime we can do that, it's much better. Age-related changes in nutritional requirements. We need less calories, but when we do take in calories, they really need to be nutritious. They need to count. So, you know, our protein requirement is the same, but we do need a higher percentage of carbohydrates, which is awesome because I love carbohydrates. A lower number of fats. Our fiber, again, which is always hard to get at any age, 25 to 38 grams a day. And again, we need to have more valuable food than we did when we were younger. Risk factors, it puts us at risk for inadequate oral care, functional impairments, and disease processes. There's effects of medications and psychosocial. You know, eating is a very social thing. So risk factors, conditions that affect the ability to obtain, prepare, consume, or enjoy food. So anytime, you know, someone can't get out and shop or do all those things or make it for themselves anymore. Cultural factors, a lot of times older adults it's hard for them to change their diet, you know, even though it's healthier for them because, you know, they've always lived this way or their mom cooked this way, or, and again, environmental and socioeconomic factors. Cost is going to be a big deal. Environmental, maybe I'm living with my daughter and she's cooking me food and I don't like it and I have to eat it because, you know, it's the only thing I can get. Lifestyle, alcohol, and smoking. Assessing GI, nutrition, and digestion. So what is their usual intake? What are their usual eating patterns? What things put them at risk for not being able to prepare their food anymore, eat it as they did before, or enjoy it? And then how are we going to measure what their nutritional status is versus what we think it may have been before? Because, you know, often nutritional status gets sort of left behind in the assessment process. So oral health is going to be a priority. Nutrition, you know, what is their weight? What is their lifestyle? What is their quality of life? What do their labs look like? Have we checked their albumin? Again, those cultural factors, those socioeconomic factors. Medication, do they have any allergies to foods? And what are their myths and beliefs? Those health conditions that can affect oral health. So dysphagia, that's going to be on page 370. Making sure that caregivers know how to do the Heimlich maneuver, that we're allowing people sufficient time to eat their food at, you know, at least 30 minutes, that we're doing good oral care, that we're managing those pathological conditions. You know, COPD, it takes a lot of energy, believe it or not, to chew food and do everything they need to do in the process of consuming food. And someone who has COPD, likely they're breathing through their mouth or they have oxygen on, and it's hard to negotiate that whole process of getting the food into your mouth, chewing it, breathing at the same time. It's a process. Medication effects, alcohol and tobacco, how are they affecting intake? What are those psychosocial factors? Those, again, cultural and socioeconomic factors, environmental factors, a little bit of a repeat on here. So some health conditions, so undernutrition and malnutrition, so those chronic infections, as I mentioned, COPD, heart failure, dementia, dysphagia, anything that can negatively affect the procurement, the preparation, the eating and digestion over a long period of time is a condition that can affect someone's oral health and nutrition. So challenges for somebody in the community, you know, as an older adult, if they were in low income or they had a lower level of education, lack of transportation or dental insurance, or, you know, maybe it was, they did have it, but it was still too high, or they had other health concerns that were more important. You know, you're not going to worry about your teeth if you have diabetes and all your medications cost $1,000 a month. You're not going to be able to do that. So, you know, oral challenges seem to get pushed to the bottom of the list all the time. And a big one, which most people don't consider, but I've been in this situation a lot, is being able to get into an office. You know, maybe it's really far away, or living in a community, or you can't get up the stairs, or you're in you know, you can't walk, and, you know, they don't have the accessibility to take a wheelchair or some type of bed into the room to look at somebody. So, and that's going to be for many different situations. So Your oral health, you know, we want to make sure we promote it. As a nurse, it is your responsibility to make sure that we're promoting good oral health. If you can't brush someone's teeth, or they can't brush their own teeth, you need to designate somebody who can do that for you. That's what our PCAs are for. That's what our nursing assistants are for. They're there to support us. We work as a team. You know, I have families that are very, very, very much into the fact that they want their family members' teeth brushed 3 and 4 times a day, and the staff pushes back. It's hard. Trust me, when you have, you know, 30 patients and everybody wants their teeth brushed 3 times a day and they all want their medication, you know, sometimes things get pushed to the bottom of the list. But, you know, it is important. You know, it's not normal to lose your teeth. It's not normal to have cavities, even though many people do. So again, I'll get off my soapbox about that, but it's a big deal. So challenges in nursing homes, as I mentioned, poor oral hygiene. You know, the patients are dependent on other people, and there's other things that, you know, just seem to be more important at the time. So we need to change our attitudes about the importance of providing oral hygiene. You know, if you were in a bed or you were dependent on somebody, trust me, you would want someone to brush your teeth 3 times a day. And also looking at the effects of medications on oral health. You know, major side effects of a lot of meds are dry mouth. You know, there's a lot of medications that, right here, 400, that affect oral health. So we have that dry mouth. We have those anticholinergic effects with the antidepressants and the anticholinergic drugs. You know, so anytime we can promote an increase in fluids, if it's not contraindicated, it's going to be helpful to, you know, helping with that dry mouth. Again, there's negative functional consequences. We discussed all of that. Getting the food, preparing the food, enjoying the food, being able to chew the food and swallow the food and digest the food, absorbing the nutrients. And then again, the big one for me is that increase to develop constipation and malnutrition. That goes back to that frail, dysphagic little old lady who has 15 meds that she takes a day, you know, polypharmacy. I do want you to look at the mini nutritional assessment on 378. It's pretty lengthy. I just want you to be aware of it and what it looks like and how you can implement that into your practice. So plan to address the following with your patients. What is their appetite? What is their bowel elimination? What are their health beliefs? What is their diet? What is their knowledge about their diet? Are they lonely? You know, is it their habit to spend their meals with another person and now they're eating alone? What is their nutritional status? What is their oral hygiene? You know, making sure when we are promoting oral hygiene and, you know, self-care, that they're using a soft brush, that they're using fluoride, that we're, you know, brushing their teeth at least twice a day and as needed. That, you know, big thing I see this a lot is the chlorhexidine mouthwash. You know, it should only be prescribed by a dentist. You know, it's over the counter now, but it is ototoxic. It should be used for less than 6 months, and I see people using it for years and years and years, and I have to push for it to come off. It can be carcinogenic. It's poorly absorbed, and if it's aspirated, it can be fatal. So it's not for everybody. We also want to make sure when it comes to oral care that we're not using lemon glycerin swabs or mouthwash with alcohol in it. And again, sensory function, what is their taste and their smell? Do they have both? Are they diminished? What is their swallowing status? What is their BMI? You know, do they want to lose weight? Do they want to gain weight? You know, is that not, you know, indicated in this situation? Again, how can we get them the food, prepare the food, consume the food? Are they living alone and now they don't enjoy it anymore? And there's a way we can help that out. How can we get them to enjoy food if they can't taste it or they can't smell it anymore, and we want some more salt added on there, but they can't have it? If they have diminished sight or smell, you know, what can we do? We mentioned a little bit of that earlier. Anytime we can make foods nutritious, there are so many different things out on the market now. This Mrs. Dash, a lot of these that have no salt in them, but have so many other herbs and spices in there that can be used in moderation to help spruce up some food. Constipation, teaching, you know, we want to make sure people understand bowel habits and what's normal versus abnormal. What was their normal before? What is their diet? What does their fluid intake look like? You know, using laxatives and enemas all the time is obviously not a good idea, but there are people that use them all the time. Again, as I mentioned earlier, allowing time to go to the bathroom, not ignoring the urge, which is tough in a community you know, everybody wants the same thing at the same time, and that person has to go at that moment, and then we ignore it because we're doing something else, and now they can't go anymore, and it's a vicious circle. And exercising is going to help this. And actually that page is going to be 378, not 375. So your evaluation, are they getting the daily nutrients that corresponds to the needs from a metabolic perspective? You know, are we maintaining their body weight within 110% of that ideal body weight for the individual? And are we maintaining that regular bowel and bladder elimination schedule? All right, that's it. Have a great day.